Invocation. Harley, could you do this, please?
Yes, I will. Dear Heavenly Father, as we gather here in the Cherokee Nation today to take care of the Cherokee people's business, we ask that you keep your hand upon us to help make the right decisions. We also ask you to keep your hand over our troops that are stationed here in the United States and those that are abroad. Bring them home safely. And we ask you to keep your hand on our meeting today and ask for your blessings. We ask all this in Christ's name. Amen.
Amen.
Hold on, Shelley.
Mary Baker Shaw. Mike Dobbins.
Here.
Bill England.
Honey.
Keith Austin.
Here.
Harley Buzzer.
Here.
Joe Byrd.
Honey.
Tom Crittenden. Frankie Hargis. Wanda Hatfield. Rex Jordan.
Here.
Vic Blake.
Honey.
Mike Shambaugh.
Honey.
E.O. Smith.
Here.
Denise Taylor.
Here.
Victoria Vesquez.
Ani.
David Walkenstick. Brian White.
Honey.
We do the form.
Okay, first up on reports, Claremore Service Unit. Oh, I'm sorry, Chris, I entertain a motion to approve the minutes.
Motion.
Second. All those in favor? Aye. Opposed? Okay.
Hi. George is out of town this week, so he sent me. He sent his report down ahead of time. I wanted to tell you all about our safety fair that we had weekend before last on June the 2nd. I think it was our biggest one that we've had so far. We had about 30 vendors, different booths, different safety units came in, and had a lot of kids come through. That's our Kids Summer Safety Fest. We had the Blood Institute came. They had a mobile blood mobile van there. We got about 15 units of blood from that, so people volunteered and donated. So it went really well. This was our third annual Summer Kids Safety Fest. It went really well, and looking forward to doing better next year. So, other than that, I don't have anything else to report. George didn't have me bring anything else down. So.
Questions? Harley?
Are we any closer, or do you know about Portable people going to the for those procedures?
I don't believe we're any closer. He didn't give me an update on that, but I haven't heard otherwise, so.
Do you know how long was it trying to do this?
Oh, my goodness. Years. At least, I've been in my position 3 years, so at least 2. So,
Thank you.
Any others? Report.
thank you.
Thanks, Kathy.
Next up, Dr. Charles Grimm, pinch hitting for him is Brian Hale.
Good afternoon.
Brian.
I know you all have the Tribal Health Committee report from the Cherokee Nation Health Services, and I'm happy to answer any questions that you all have about the report that you have. And I know there's at least one question I need to address about some software for ECGs, but I do want to go ahead and lead off with a brief statement. We had a brief lapse in protocol at Hastings Hospital earlier this year between January and April. A nurse was administering medications incorrectly. The nurse used the same vial of medication and syringe to inject more than one IV bag. Patients were never directly in contact with the needle, and in all instances, the medication was administered into an IV bag or into the IV tubing. The likelihood of bloodborne pathogens traveling up the lines into the IV bag and causing contaminations is extremely remote. Out of an abundance of caution and concern, after consulting with our infectious disease specialist, we recommended that 186 patients return for some laboratory testing as a precaution and for our patients' peace of mind. The results from every patient thus far, which is 89 to date, show no harmful exposure, and it's reinforced our belief that patient health is not at risk. We will offer retesting to all patients at 6 months, and all patients except 8 have been notified at this time, and we're still working diligently to try and contact those who remain. The nurse responsible for this lapse in protocol is no longer employed by Cherokee Nation. So I hope that helps allay some of the fears. And there was a question about some software being purchased to alleviate some confusion about getting test results back from electrocardiograms. And I do want to let you all know that we are working on a software platform being implemented that's at the recommendation of our physicians. It'll help us better manage those cardiology studies, such as electrocardiograms. It's seen as a better method than the current one, which is to electronically scan these ECGs and then attach them as a scanned image to that patient's medical record. And we are currently working to complete that interface between our electronic health record and the new software platform. And I'm happy to try to help answer any other questions about that.
Councilor Lay.
Thank you, Mr. Chairman. Appreciate it. Brian, I've got your, I think, statement about protocol here now. Was that ever sent company-wide or to the council, or that's your word?
I sent a statement out to health services staff Friday evening.
And how do they handle that then? Does health services have a spokesperson in the sense that the tribe does and CMB does?
We typically just use the tribe spokesperson.
And I can tell you, I can't find anything about this protocol. It was on 6/11. And of course, a lot of them started getting phone calls. Not so much from my community because of Hastings, but simply asking me, did this happen in our clinic? Did it happen at the hospital? Those sorts of things. If you guys, let me make a suggestion to arrange to have a media outlet or a spokesperson, and if you could inform council, we're the rubber on the road. We get these phone calls first. You all know that. You've been knowing it for years. The chief knows it. He's been knowing it for years. We'd like to be informed as to what's going on. And to be blindsided by it is not good.
I understand.
Not a good scenario. I know you're stepping in today, but I hope you carry that message back. Whoever's watching this telecast, I hope they understand that the council's going to get these phone calls. We're the closest folks to our people. That's the way this is set up.
I understand.
We need to know. We need to know what happened so that we can explain it. Thank you.
David?
I've been contacted as well by many of these affected patients, and one of the things that they were telling me is when they were contacted, they said there were some some air ducts or something wasn't clean, and there were some utensils that wasn't sterilized properly. And so, I trusted the communication from our health to these affected patients that was the validity of what happened. And then we got two different newspaper reportings. One was from Cherokee Phoenix, and then on Channel 6 had something last night, and it's totally opposite than what was communicated to the affected patients. What was the directive of communication to our staff in communicating this lapse of protocol?
We had a very narrow script that we asked the nurses to adhere to. I've heard also the thing about the air ducts, and I don't know where that came from. That was not anything that we advised them to say.
What was advised to say because this is a sensitive matter, what was advised to tell these affected patients?
That they needed to, out of an abundance of caution, come in and be screened.
Okay, they didn't know what for?
No.
Okay.
We told them what we were concerned about, but that's all.
So this nurse, evidently it gave us a lot of negative attention because there's a lot of great things that go on at Hastings Hospital. But this nurse, so that they're no longer practicing in our clinic. Is that correct? Okay. Did they get their license revoked, or were they turned into a board?
I don't know the answer to that.
Okay. How was this handled as a disciplinary as from our HR standpoint.
I can't make any comments on employment matters, sir.
Okay, well, maybe following these questions, we can go into executive session if this body's willing, because I think many of us have received these same phone calls, and we like to get the story straight for us, so that we'll know what all happened through all this. So, anyways, that concludes some of my questions right now. Thank you, Chair.
Mr. Taylor, of course, I've had 2 constituents call me. Some of this that I just walked out of my office and seen and scanned and you went over, I'll try not to double these questions, double the info you gave us, but the constituent may or may not be here with us today. So I want to make sure that she gets her questions answered, and you know, as well as I do, that's our job.
Right.
They come to us, we come to you. So I've got a few questions here. So one of them was wants to know how she would find out if she came in contact with the nurse in question during her surgery in April.
Any of the patients that we believe were at potential risk, we've identified and contacted. And we believe that we acted in an abundance of caution, that we cast a pretty wide net. So anyone that should be concerned, we've made contact with.
If she wanted to know, though, if she came in contact with the nurse in question, could she find that out?
I'm not sure how she'd go about that, but I'm happy to visit with the patient and see if we can help her with that.
Right. And I know you're standing in for Dr. Graham today, but that'd be something that if it's weighing on her mind, that'd be the least we could do is get her all the information that she's requesting.
Okay.
And so I might send these to you later too. And what did the nurse actually do? It's considered a brief lapse in protocol. So it had nothing to do with the air ducts. It was the IV and the syringes here in this information.
Yes, sir.
Right? And now, when was this brief lapse in protocol first reported to administration, to health administration?
At the end of April.
And was the nurse put on leave pending an investigation?
I can't make any comment on employment matters.
Okay. And what type of training, certification, and license did the nurse have? Can you
Again, they were functioning as a registered nurse.
functioning as, so that'd be certified?
Yes.
I just got 2 more here. So did the nurse actually administer medication to me? Not me, but the constituent. If so, what kind? Of course, that's going to vary from case to case. But how would she go about finding that out if the nurse actually administered her, and what kind of medication?
If you want to send me that information, I'd be happy to follow up with the patient and have the chart reviewed.
Okay, just one more here. And her concern, like Counselor Walking Stick, is, I assume because it was faster, the phone call, but she was wanting to know why didn't the 186 people receive the info in writing. This particular one was in her car, and was just presented offering her some free blood work for a lapse in protocol, and it frightened her. And so the presentation was frightening. I mean, I know how I even feel about just going to a routine, but just the presentation.
Well, we had a lengthy debate about the best method of notifying patients, and we felt that in the interest of protecting their privacy, a phone call 1-to-1 was the best way to do that.
Now, whose job was it to do that? Just a clerk, or?
No, sir. We had an infection prevention nurse. And we tried to limit it to 1 or 2 contacts so that we could stay on message and make sure that people had a point of contact that was easily reached.
And yeah, if you don't mind, I'm going to send these to you and just kind of highlight some answers. We've already answered some of them.
Okay.
But, and we can contact you in different cases. Like I said, I've just got 2 in my neck of the woods so far. But just get with you on any of the private things
Be happy to
maybe
help
in
with
their
any of
file.
that. Yes, sir.
Thank you.
I got one question over here.
Hey, Brian, so you and who else will be taking on, like Counselor Crittenden wanted some of his constituents to come and see you. You and who else are going to be
I
accepted?
can be the primary point of contact.
Okay.
Brian, and I think I've got your, oh, I'm sorry.
No, is that, I'm trying to help anybody else that might have constituents that have called. I've got one phone call, but I followed it up with one of the medical people there, so, but if there's any other constituents, so they come, you're the point contact.
Yes, sir.
Okay, all right, thank you, Mr. Chair.
What percent of these? Concert. What percent of these patients have been contacted?
I think we have all but 8 notified. We're still working on notifying 8 that we've not been able to reach via phone. And we've also been sending out public health nurses to make personal contact with folks.
That's good.
Just one follow-up. Thank you, Doc. Brian, were these all over on the medical field or in the dental field? There's stories running around about a dental patient.
Some patients that have involved dental procedures that require anesthesia or moderate sedation, those cases are performed in the operating room.
So it's a crossover.
Yes.
Thank you.
The few patients I've visited, they've asked Hastings Hospital to give them the record, and they've all said that that they need to get a new record, a new file, and because they were wanting the information to see who was the nurse, I guess, and so, but one of them was able to obtain the document through Contract Health. The rest of them had to submit a new file. Is that
What they're probably asking for is a release of information to give them that medical record.
okay? Right.
That's what's generally required for us to give someone their medical records, is they just have to sign a release.
Okay. All right. Well, if no one has any other questions, go ahead.
I have a question, I have a comment. It's kind of obviously a touchy situation, and it's an unfortunate situation, but I think I'm looking at it from the fact that I do appreciate for the councilman what you've done to identify these people who may be at risk, to get a hold of them and try to go beyond a doubt that, whether there is something, there is anything wrong or there's not. So I would like to say thank you as a councilman for doing that and expediting the process.
I appreciate that.
And letting us know what's going on today. I've read your release, so I'm confident that, once everybody's contacted, that we probably won't have any problems, it doesn't sound like. So, but again, thank you for what you've done in identifying those people.
Yes, sir. Thank you.
Any other questions? Brian, you want to continue your report now?
Sure. I believe the next thing that we have, unless you all have any other questions about anything in the Health Committee report, is we wanted to give you all an update on the status of our joint venture construction project. And I'm happy to try to help answer any questions that they don't answer. I will tell you that we have a monthly meeting with the architects and construction management firm, and that we are continuing to stay on track in regard to schedule and budget. And again, looking forward to opening that new facility in September of 2019. And I'll ask, I believe we have Lacey to give us the presentation on the JV, the WC. If you all are ready for that.
Counselor Taylor, did you have a question?
I have a question not related to the lapse. I've gotten several calls regarding the phone system at Salina. They call, it's either not answered at all, or it's answered, please bear with us. They're on the phone for in excess of 30 minutes, they tell me. Usually they either hang up and redial or hang up and drive in. So I don't know if there's an issue with staffing there or just what, but that's not acceptable for patients. A lot of our patients are elderly, you know that. an extra trip to the clinic is an inconvenience for them, and we need to have somebody answering their calls.
I'll follow up, find out what's going on in Salina, and get you an answer.
Thank you. That's all I have.
Brian?
Brian, very similar to what Council Lady Taylor was saying. I know when this stems at the pharmacy at Redbird, Councilman Smith and I both the last week or so, and I understand there was some training and some other things, but that they did at that time. But I know that the patients, they're trying to call in, and a lot of these we know are elderly, and then if they don't have those meds and they don't have those things, we've all went through this quite a bit. But just and I talked, and the clinic administrator there has been working with me very well to look into these things. Just kind of give him some backup and help him out down there. I don't know if it's staffing. I know we're down a pharmacist there. I know we were looking to get a locum in there. So that's one of the big things that we're looking at Redbird, as well as physicians, as Councilman Lay always points out. I'm getting in line. Yes, sir. Thank you.
Harley?
Brian, what's the policy through the health department on cell phone? I know the Cherokee Nation has unlimited amount of cell phones, but if we call the clinic, or if a person calls the clinic and want to get in contact with somebody that's in the field that has a cell phone, is that clerk allowed or not allowed to give that cell phone number out to a person?
It's going to depend on who's calling and what that provider's preference is, or what that person's preference is as far as giving out their mobile number. Generally the rule that we kind of follow is if you have a Cherokee Nation phone, you're expected to share that number.
That's my philosophy. I think everybody on this council has a cell phone, and we certainly don't hide our numbers. We give them out for people to call. My feeling is if you call a person or a clerk and ask for this other person's cell phone, they should give it to you, because you're not going to call up there just to chat. You're calling up there because you need some type of medical services. So anyway, I don't know what your policy is. You made a couple of statements here. I'm not sure what's which, but I feel like if a person or a patient calls and asks for a cell phone number, they should give it to them. I don't think they're going to call up there just to carry on a conversation. They're calling for a reason. And most of those reasons are either for transportation or health issues. So you clarify that with all the health department, I appreciate it. And that's going to say with any other department within the Cherokee Nation, if we're paying for those cell phones, those numbers ought to be available. So that's my comment. So if you take care of that, I appreciate it. Thank you.
Buell?
Yeah, thank you, Mr. Chairman. Brian, I have been contacted by a lady that's going through the nurse practitioner, and she's going to graduate in August. She's tried several times to get hold of the recruiter and can't get a return call. She sent them an email, and she still hasn't heard back from them. She graduates, I believe it's, she's graduating in sometime in the very near future. She wants to work for Cherokee Nation in Cherokee. If I give you her name and everything, would you look and find out why she's not getting a return call from the recruiter?
Yes, sir.
But she's reaching out to us, and we're not responding back.
Okay. Yeah, if you want to give me her name and contact information, I'll see that someone follows up with her.
I'll do that. Thank you, Brian. That's all.
Any others? John?
Okay, Brian, I had just a couple more. I have now the time frame that something like this could have happened is, what is that, January to
April.
And is that based on when the employee was there, from January to April?
That's based on, yes, when they were working there.
And so January, I had a lady that their kids had a surgery in August, and so she's, of course concerned. And the last question I'll have is, and like Councilor Shambaugh said, I appreciate what you guys do. A lot of people getting good health care, but as like we stated earlier, our one obligation truly is to these people asking us questions. So, and they presented to me that it was had to be kind of a rushed thing, and from what I'm getting, not the best presentation of a phone call is, hey, you can do some blood work, and we're gonna test you for this and this and this. Lapse of protocol, see you later. You know, so that, no disrespect to you, but that was kind of rushed. But if we found out in April, what was the holdup being, as a tribal counselor, I've got this June 11th or 12th, whatever it is.
Well, as soon as we knew about it, we had our safety folks and our quality management folks start looking into it and identify those patients that we needed to contact. And we felt like, just to protect their privacy, we wanted to contact them via phone or in person. So.
All right. Thank you.
Brian?
Yes, sir. Thank you, Don. Brian, just on this, I think that we see on a situation like this, you know, where you get a wide variety of assumptions and things, so the importance of getting that, you know, and I do applaud you guys for getting around that. I know a lot of us, we feel like that maybe it should have been earlier, but I mean, there's a lot of steps to identifying that, and I appreciate that. One thing that I would ask, the phone call that I got from a constituent, and was, you know, make sure you guys follow up with them on those results, because they had been left, you know, sitting there about a week or so without, just maybe following back up. They've been taken care of and everything, but just make sure that we get back with them and help them to understand that this process is not going to just be a short process as well. So I appreciate you. Thank you.
I think going forward, I think we'll all have constituent concerns that we need to address, and I think Brian's the point man on that. I think a lot of these concerns can be handled through Brian. I think that'd be the proper vehicle to handle.
Chairman, I got a question.
David?
What's the chances of backflow with so the situation that I'm not a medical person, but so there was a syringe that went into the arm, the IV, and then there's a tube that goes into the medicine bag. So the issue was the syringe or tubing that went in the medicine bag was used on multiple people. What's the chances of the blood or contamination backflowing into the medicine bag? What are those chances?
I couldn't give you a specific percentage. I will tell you that our experts say it's remote, but they felt it was prudent to go ahead and conduct the testing.
Is there a chance that it could be contaminated?
They felt it was remote, but there was a slim possibility, and because there was, even a slight risk, they wanted to go ahead and screen them.
Okay. Mr. Chairman, if there's not any other discussion, I'd like to move into executive session to discuss the personnel matters with the employee with the entire council.
I'm not sure that warrants a executive session,
If
Council.
it talks about an HR issue, we can't.
I'm not for sure he can reveal the HR issue at this point.
I can't discuss it.
In executive session?
Still by law, personnel matters are confidential. So even being an executive session, I don't know what else that Mr. L can, I mean, if you're asking for names or details, we won't be able to share that even in executive session.
At this point, I really don't want to know till you've done some more due diligence. I don't. I mean, other councilmen.
I think it's a serious issue with the disciplinary actions, because if this person is practicing at another health facility, we're putting someone else's life in danger. That's what I want to know. And I need to know if their license, one is, are they still an employee of Cherokee Nation?
No.
No. They're not an employee of Cherokee Nation.
No.
It's right there in your report.
Bottom line.
And the other is he practicing or she practicing at another facility?
I don't know the answer to that.
That's the reason I like to go into executive session, to get these answers.
Brian, it would not be Cherokee Nation's responsibility to revoke a medical license, would it? I mean, we have our due diligence to report the incident, and we're not a licensing agent,
No.
therefore we can't give or revoke.
No.
That's my only question.
Did you report it?
Cherokee Nation Health Services has not reported it as of yet.
Are you guys in the process of doing that, or
It's going to be considered.
can be considered? Is that negligence on your all's part for not reporting it?
No.
So you're gonna put someone else's life in danger for malpractice?
We don't believe so.
I,
If it takes a second, I'll second the executive session.
that's ridiculous. Hey,
Well, we
Chairman,
have a
I'll
motion.
make a motion. for
Motion to
executive
go into
session.
executive session in a
Second.
second. Okay. All those in favor, say aye.
Aye.
Opposed?
Aye.
Roll call, yes. Executive session. No. This is a roll call to go into executive session. Yes. To go into, no. Not to go into.
And it takes 2/3. David Walkenstick,
Yes.
Brian Warner,
Yes.
Bill England,
Yes.
Keith Austin,
Yes.
Harley Buzzard,
Yes.
Joe Berg,
No.
Sean Crittenden,
Yes.
Mike Dobbins,
No.
Frankie Hargis, Wanda Hatfield,
No.
Rex Jordan,
No.
Dick Lay,
Yes.
Mike Shambaugh,
No.
Mary Bakershaw,
No.
E.O. Smith,
No.
Janice Taylor,
Yes.
Victoria Vasquez.
No.
We have 8 yes, 8 no. That is not 2/3.
Okay.
Motion fails.
Okay. Brian, are you through with your report, or we still got more going to report?
I'm done with my report.
Okay. Now we're
Brian?
ready for,
I have one more comment on the concern of this person that is no longer with us. Now, you will follow up, and usually they get a letter, a recommendation, or from our place when they're seeking other employment. Correct?
Typically, we don't give a letter of recommendation. Basically, what HR would typically say is if someone is eligible for rehire or not.
Okay.
That
But
should
they
be all
will,
it
they
is.
will call, I mean, they'll always usually check the last place of employment.
That's correct.
Always. Okay. If you don't check the last place of employment, then you're hiding something in most places. I used to work in HR. So, well, let's make sure when they do check, give our HR heads up on what we want the answer to be.
Okay.
Okay, that's all I ask. Okay, thank you, sir.
Harley?
I just want to make a statement. I think it would be the best interest of the Cherokee Nation to report this person to the medical professions. That way the job is done. If we say nothing, I think we're just opening ourselves up to putting people out here to administer medical service to other people. That's not the right time to do, and it's not the right thing to do. I think the right thing to do is report this person. But anyway, that's my comment.
Harley? Sean?
Brian, will you give me that cell phone number?
Yes.
Just text it to me or tell me now or?
Sure. You want my cell phone number?
Yeah.
918-316-0535.
Thank you.
Got one.
Junior?
When she applies for another job, I know this from, but anyway, reason for dismissal, will that not be exposed, or does HR allow, are they allowed to do that? To tell why she was dismissed?
I'd have to let HR answer that question.
Okay, you good? Well, Dick?
I'm sorry, Doc. Each question gives me another question, and I apologize to the group. Y'all know how I am on my questions, so. And so this, I think you said this person is no longer working with us.
That's correct.
Is that with Cherokee Nation Health or Cherokee Nation anywhere?
To my knowledge, they're not working for Cherokee Nation at all. I know they're not in Cherokee Nation Health.
Right? And so, I better stop there. Thank you, appreciate it.
To answer Councilor Smith's question, any time that an employment reference is checked for any Cherokee Nation employee, the only information that we give are dates of employment and whether or not that person is eligible for rehire. So that is standard across the board. If someone calls and says, Chrissy Nemo listed on her resume that she worked here. Can you confirm that? We confirm dates and whether or not they are eligible for rehire, and that's it.
Any others? So that concludes your report.
Thank you.
Now, we're no old business, new business, now joint venture presentation.
Good afternoon, Tribal Council.
Good afternoon, Lacey.
So in response to a request from, I believe, your last health committee, there was an ask that there would be a presentation on the status of the WW Hastings expansion project. And since Dr. Grimm wasn't going to be here today, he reached out to WC and I, who gave a presentation on the status of the WW Hastings expansion project to the group of bankers that contributed capital to our loan that enabled us to build this facility. So what I have here is my presentation that does have some basic information, but maybe you find it interesting, but also gives a bit of a status update as to where we are. And I know that WC will get into some of the finer points of it as well. So hopefully you will find this informational. So as you know, Cherokee Nation operates the largest tribally managed healthcare system in the United States. And in 2017, our healthcare system had over 1.3 million patient visits to our 1 hospital in Tahlequah and 8 ambulatory clinics throughout the nation's 14-county reservation. The funding for our facilities is through 3 primary sources: IHS Self-Governance Compact, third-party revenues, and competitive federal grants. And health has experienced major growth in our third-party revenues, and it's potentially estimated that we would see an additional $20 million above and beyond our initial revenue estimate for this year. So just basic information on a joint venture. You know, what is a joint venture? The tribe is agreeing to build and equip the facility, and in turn, IHS provides the operational funding. This award is the largest outpatient healthcare joint venture center between the IHS and any Indian tribe. And we were awarded this joint venture through a competitive application process where several categories are considered, but the largest determining factor is need. And so all of us who've been to Hastings can certainly attest to the need of an expansion of this facility. So we project the facility to partially open in July of 2019, assuming all goes well between now and then. The current FY19 congressional justification proposal for funding the facility is $26 million for July through September FY19, with an estimated startup of 200 new positions. So in other words, the President's budget and Congress have already been looking at $26 million for an interim appropriation for us. So going forward from 2020 and beyond, we're estimating anywhere from 80 to potentially over $100 million increase in our Indian Health Service funding annually for these expansion operations, and approximately 800 new positions being added. So I know this is small, but I just sort of wanted you to understand, you know, with old services being on the left and new services being on the right, how we're not only expanding existing services, but we're also adding new specialty services such as cardiology, orthopedics, dermatology, endocrinology, urology, and neurology. And making these specialties available, quote, in-house will enable us to keep many of our contract health patients within our own system. Good drone pic there. And then here's the rendering. I know that many of you have seen that, but I'll play that towards the end. And overall, the construction project is moving along on schedule and on budget. The project is 35.9% complete as of March 31st. And at every stage of construction, we're continuing to review opportunities for the nation to take advantage of any cost savings available without jeopardizing any integrity of the structure. We've encountered no issues or problems with contractors or vendors, and as of this date, there have been no major injuries and no material losses of supplies on the site. So our loan advance, in which many of you may remember we did a $170 million syndicated bank loan, We had a very intricate schedule of loan draws that was associated with that. When we put that loan forward to the bank, that draw schedule forward to the bank, we estimated that at this point in time, we would have drawn $77,086,233, and our actual advance at the same period of time is $76,570,500. So we're just $500,000 off of what we projected we would be at this point in time. And it's estimated that we will begin drawing down funds from the remaining $55 million of committed capital from C&B in approximately December of 2018. So brief discussion of the local economic impact, and I know WC will discuss a little bit of the national and international economic impact this project is having in a few minutes. But 800 new positions means that new people will move here, new amenities and small businesses will crop up to support the growth. And it will bring in many more vendors, patients, and families from all over who will be dining, shopping, and potentially lodging in the area. And so creating a strong positive impact on our capital city. And so that concludes my presentation. Do you have any questions?
You mentioned the financing. What, you said grants, there were 3.
So the funding for our current healthcare system is our IHS Self-Governance Compact, which provides our base level of funding. And then we have third-party revenues that are the insurance collections that we receive from third-party payers. And then we also go after numerous competitive grants that provide those ancillary services that we are not able to fund with just our base level funding.
Thank you very much.
You're welcome.
Thank you.
Other questions, Lacey? Dick?
W.C. Gurnett, good to see you.
Good to see you.
So when is this going to be finished and completed?
Per our contract with Flintco, September 2019 is the date. We're looking at the progress right now as Treasurer Warren said, the possibility of in July.
We're going to open in July, part of it or
Partial.
partial?
As we see fit, we're doing a priority list right now with health departments where we can start getting in. Health has to do their simulations, basically getting staff acclimated to the building, and therefore we're evaluating those departments to start getting them in and ready for the big one.
Thank you.
Hey, Lacey, pardon me if I had a text or two if I missed this, but can we just remind everyone listening, so we funded the building and the operation, right? Cherokee Nation.
The building and equipping.
Building and equipping. All right. Operation, we're to get how much a year from federal government?
$80 to $100 million.
A year. For
Perpetuity.
for how many years?
In perpetuity.
In perpetuity. That so
Long enough.
That's a long time.
No question about it.
I do understand that the IHS joint venture contract is a 20-year contract. Is this correct? However, the precedence is that they will continue that after the contract period has expired.
No matter who's
Right.
in office.
Once this funding is added into our base funding, it should never, ever be clawed back.
It's a 20-year contract.
Yes.
And is that whatever that word was means? 20 years?
Perpetuity?
That means 20 years?
What I'm saying is that there's 20 years, but there's a precedent that they would not reduce our funding amount by that amount. So they would be breaking precedent with what they've done. So yes, essentially it is in perpetuity.
Essentially. Thank you.
Lacey and WC, how are we with the other infrastructure that goes with it? I'm talking about roads. Are we looking at warehousing any equipment to support the new clinic or the hospital? Especially the roads. Well, insurance had a meeting about the road. How's it coming along? They coincide with the opening.
Yes, Cherokee Nation Roads Department has a separate project away from this that is being driven by this project. Ross Street is having an update to it, which increases utilities, upgrades those, widens that road, and provides turning lanes for the main entrance, which will be to the new facility now, and be an also alternative entrance for the hospital. We also have a secondary service entrance that's a little bit further to the east side of the property that is going to be included in that. So basically, we're raising the road heights as well, and that road is going to be safer for not only the patients, but for the neighbors. That roads need some updates for a while, and Roads has had this on their radar, and it's being pushed by this project.
So there will be an entrance other than coming off of Downing Street now?
Yes, sir.
Okay.
Yes, sir. There'll actually be two, one being a service staff entrance to the east side of the project, and then the main entrance. So we'll have two large entrances coming in.
The other question is on warehousing, inventory and stuff like that. Have we made arrangements for that, or what are we gonna do?
We have, CMB has worked with Cherokee Nation to provide the Woodmark building for warehousing. When the floods and fires started happening around the hurricanes, we were concerned about materials, being availability-wise when we needed it, because we have a deadline for this project, and also for the increase in cost that comes with it. So CMB allowed us to use a large portion of that facility for what we need to do.
So-
Ordering early, and then with the, as equipment comes, storing there as well.
That was my concern.
Sir.
Electrical, I see they're doing a separate substation out on site.
Yes, sir.
Is it gonna be online and ready, or is it ready now?
We are nearing completion on the OG&E substation. Our scheduled date was in August of 18, but as Treasurer Warren alluded to, we're moving up a little bit in schedule, so we're hoping that in July that we'll see that ready for permanent power to get to the building.
Was there any consideration, or is there any solar heat, solar power stuff on this?
We evaluated the opportunity to do that in our lead requirements, but of course, the upfront cost and then the overall maintenance of that was not up to, it was not a desirable item to pursue. So we left the solar power off of that.
Was the electrical substation, was that, who put the cost up for that? Was it the Cherokee Nation, or was it the PSO?
OG&E,
OG&E.
actually, we worked in agreement with them.
Thanks, sir. Thanks, sir.
Yeah, Lacey, I feel like I'm back at Devine school days.
Yeah.
Since I asked the question, let me make sure I got this right. 20-year contract, that we're gonna get this money, but there's a precedence. There's a precedent to just say, by golly, we're gonna approve that 100%. Is this 80-something million coming in forever, no questions asked? I think that's what I was trying to get at.
So, Counselor Crittenden,
Mm-hmm.
the appropriations process at the federal level is that Congress sets the appropriations.
Okay.
So there's always a question whether we're going to get another dime or another dollar from the federal government. So can I sit here and give you a guarantee that it will
I'm like you, I hope it does.
be in the budget forever?
Well, I hope it
But
does.
the precedence is that once these joint venture projects are put in place, because Congress understands that the Indian tribe has put up a significant amount of resources and capital towards these projects, that the 20-year contract will be honored on a go-forward basis after that contract has expired. It's not savory to add funding into an Indian tribe self-governance compact, which is how this will come to us, and then take that back. And then we're sitting with a huge asset that we have,
Costs a lot to run.
right, cost a lot to run, borrowed money, used our own capital to pay for. So obviously nothing is certain. Tomorrow's not certain. But as far as this type of funding and the precedent that has been set in the past, this is reasonably assured that we would receive this in perpetuity.
Perpetuity.
You learned a new word today.
Thank you.
Hey, Lacey,
Yes.
back to what kind of Sean was asking there. So the $80 million that comes in, is that the first year after completion, turnkey in 2019, that we're gonna receive 80 million, or is it based off a percentage of employees that we have, and we're gonna get only a percentage of the joint venture?
My understanding is it's the full year funding.
So it's gonna be 80 million right after turnkey?
Yes.
Okay, so,
Well, so they've even incorporated some funds for us next year. So that's what I was saying. There's the $26 million that they have asked Congress for to give to us for the startup period in between now and FY19, when we have the building fully completed and ready to go. So it's my understanding, and it's Dr. Grimm's understanding, but we're kind of seeing this as, as we see the information come from Congress.
sure.
And so the information came from Congress just a few months ago for our 19 funding. So we'll know more about their 20 budgets
Sure,
a few months down the road.
Yes, contingency. The contingency of funds anyways. So there's 800 to 900 employees that's supposedly gonna staff this hospital. Okay. Of course, we're all aware of the shortage of docs, and I don't want to be pessimistic here. I'm a highly optimistic individual, but it's going to be a challenge to fill that hospital after the first year. Okay, that the hospital's ready on turnkey with 800 to 900 positions. Okay, so let's say hypothetically that happens and we don't have enough staff to fill that whole entire hospital. That $80 million that we get every year, is that money just going to be carryover? We're just going to keep building up this $80 million nest egg for however long till we get our 800 to 900 employees there at the hospital? Okay.
Any unspent funds would roll into carryover. That is correct.
Man, that's amazing. Huh. It's a good deal. Thank you.
We want good deals.
Yeah, we like good deals.
This is a good deal.
Mr. Lacy?
What percentage, you may have already answered this, what percentage of the direct loan that we took out, what percentage have we spent?
Help me. Oh, how much of the loan have we spent? We're about 40%.
Okay. Not bad. Are we still
Yeah.
under budget?
Yes.
WC?
Confirm that.
Sir.
Good job.
Many thanks to WC, and I think he's got a few slides here for you as well.
You guys ready for me?
You just have to.
Good afternoon. My name is W.C. Gurnett III, with the Cherokee Nation Businesses Corporate Construction Department, Senior Project Manager. I'd like to start off by thanking the committee for allowing me the time to give you guys a quick update of the status of this project. I'm going to go over some project specifics. Treasurer Horn covered some of this, so it might be duplicated, but it's all great information. 469,000 square foot multi-story structure on trust land. The expected total staff is over 1,200. IHS joint venture project. IHS will provide the funding for staffing and operation of the facility. It is the largest Indian Healthcare Services joint venture agreement between the United States government and a Native American tribe in history. The largest IHS joint venture outpatient health facility in the country, and the largest single project Cherokee Nation businesses have completed. Cherokee Nation businesses and Cherokee Nation planning and development are the Cherokee Nation's owners' representatives. HWH is the program manager for CMB, Cherokee Nation. Childers and HKS are the architectural engineering design team. Glencoe is the construction manager. And there are 5 expert third-party consultants inspecting and reviewing the project documents and work to protect the Cherokee Nation and our partners' interests. These third-party consultants are experts in the engineering fields of civil engineering, structural engineering, mechanical, electrical, plumbing, life safety, and the building envelope. It's an added layer of protection for us to ensure that the construction manager and all the trades are building the project per design specifications and are abiding by the state and local federal codes. The multi-state economic impact. Of course, the Cherokee Nation and the state of Oklahoma benefit from the funding for this project. However, there are companies across the country that are partners in this project. Materials and equipment for this project originate from various states. Furthermore, we have some partners that are based outside the U.S. The WW Hastings expansion project has created opportunities for businesses across the country. The economic impact is an excellent example of how the Cherokee Nation's continued growth can have a positive impact on both the local and national economy. The states on the map that are highlighted in green are where our partners reside and where the money is going. It's such a large project, we have to depend on others. We keep as much here as possible, but that's pretty impressive. And that is excluding the international partners that we'll have for equipment. Project status highlights. We topped out the steel structure on March 9th of this year, which also marked 1 year of construction. It's pretty impressive to think about the groundbreaking we had and to go out there and look at that building now. It is quite a feat for 1 year. OG&E substation completion is in progress. We anticipate the completion August 2018. As Treasurer Horton alluded, we are bumping the schedule some because we're doing well. We've had good weather, so we're hoping possibly July. Interior framing, exterior finishes, mechanical, electrical, and plumbing are in progress throughout the site and the building. The central plant is on site and installation is in progress. Just to show you how big the equipment is, Councilor Buzzer was asking about, the central plant is an expenditure totaling over $5 million by itself. Parking and concrete paving is in progress. The project is on schedule. Construction is under budget. Economic development. At 469,000 square foot, the Hastings expansion project requires upgrades to the local utilities that meet the needs of the facility. The upgrades impact the existing electrical, water, sewer, gas infrastructure. Additionally, the project has increased local competition and providers for cable and internet services. And this is due to the installation of redundant providers at the WW Hastings expansion. An upgrade to the Ross Street through a separate Cherokee Nation Roads Department project is being driven by the construction of this project, which will provide new and safer road for our neighbors and our patients. It is estimated that approximately 1,000 construction industry professionals will be performing work related to this project. Again, the reach and the size of this is impressive. The facility will create over 800 new employment opportunities for healthcare professionals and support staff. An increase in population is a reality, which will increase the local tax base here in Tahlequah. The increase in revenue for the local economy through lodging, dining, shopping, fuel, and building materials is being realized now from the influx of workers. All the factors listed present strong potential to see increases in property value in the future, which is a benefit to the community in our nation's capital city. LEED and the benefits. LEED is leadership in energy and environmental design. Pursuing LEED certification requires a commitment to incur a higher upfront cost for the project, which was evaluated. Part of Councilman Buzzard's question about the solar power is part of that evaluation. We have to evaluate what point base we're going to go on, which cost is related to. The point breakdown is LEED certified at 40 to 49, silver 50 to 59, gold 60 to 79, and platinum is 80 plus. Per the IHS agreement, our pursuit is LEED certified at minimum. Currently, we're at 52 points, which puts us at silver, which is fantastic. And we have 9 more possible points that would put us at gold. Gold's possible, but we have to analyze our ability to achieve it with cost and our deadlines. The energy savings requirement with achieving LEED certification will produce operational cost savings. Key aspects are energy savings, which is a positive return on investment. Low volatile organic compound material use, which provides a healthier indoor environment and less impact on our exterior environment. Sustainable operations and maintenance, enhanced commissioning, which ensures the mechanical, electrical, and plumbing systems operate efficiently and that the staff is trained on how to operate the building. Pursuing LEED provides operational cost savings and, more importantly, LEED reduces the carbon footprints, which is beneficial to the posterity of the Cherokee Nation, so the cost is easily justified. In closing, I'd like to say that the WW Hastings expansion project is a once-in-a-lifetime project for most construction professionals, including myself, in this region of the United States. I'm Cherokee. I'm proud and honored to be a part of this project, not just for the invaluable experience, but for the ability to be a part of providing a sustainable building that's going to provide quality health care to the Cherokee Nation and other Native American tribes. The project team is honored to be a part of this monumental project. We're proud of the work we've completed to date and hope that you're pleased with our progress. Thank you to the tribal administration for ensuring, and each of the tribal council for ensuring that quality health care is available to Cherokee Nation citizens and other Native American tribes across the country for the future generations. Thank you. Thank you for your time. Have a great day.
Your report, David C.
Sir.
Yeah.
Any questions for Lacey or Legacy? Very thorough report.
Very impressive.
Appreciate the update.
Thank you.
WC, what you might do sometimes in the near future is give the council maybe a tour of that.
Just let me know.
Okay, get with Gail, and they may have to split up in 2 groups, but get with Gail, maybe the ones that would like to take a tour of it, because it is impressive.
Yes, sir.
You guys are doing a great job. Appreciate you.
No local shoes, Joe.
Okay. No cutoffs, no sandals.
Okay, next up, discussion, we're just going to discuss medical school scholarships. I left you some data there for the purpose primarily for you to go home and look at those figures. I don't want to get bogged down in those figures necessarily today, but I just want to bring this to the attention of the council as perhaps being proactive in trying to get more Cherokee physicians in our Cherokee clinics. Right now, it's very difficult even to encourage Cherokee students to consider a career in medicine. They're kind of overwhelmed by the admissions process, and then they're overwhelmed by the cost. And this is just an idea. There are some other tribes that are starting to do this, and most recently the Navajos have entered into an agreement with the University of Arizona to fund 6 Navajo medical students a year. Of course, they're very isolated. They had to do this in order to get physicians into their medical clinics, but they have been proactive in doing this. Right now, most of you probably know our Cherokee students that go to medical school, they fund it through Indian Health Service or IHS service scholarships. They're fully funded through the IHS. Most of you may not know, though, there is a service payback. In other words, if they are funded 4 years in medical school, then they agree to serve 4 years through an IHS facility. So there's a service payback. And I think if we decide to go down this road, I think we should probably model that IHS way as well, to have a service payback. In other words, if we as a Cherokee people decide to pay for the medical school education 4 years, then we would ask them to serve 4 years in our clinics. So it's not like our undergrad scholarship where we give everybody $2,000 and we don't expect anything in return. It's just there. But this would involve a service payback. I just think this would be an encouragement. I think the word would get out. Hey, the Cherokees, if I want to go into med school, they're at least going to help me get through school. I think that word would get out, and along with the IHS possibility as well. It's kind of a long-term strategy. If we decide today to do something, we probably wouldn't see the fruits of this investment probably for 6-7 years down the road, because 4 years of medical school, then they go into generally a residency, which is 3 or 4 years after that. Then the service payback would kick in then. In IHS, after 4 years of medical school, the students enter into a deferment until they get through the residency, and then they go into their service payback. So I would think if we decide to do this discussion only, I just wanted to kind of check the temperature of the council to see if this is something we want to look at. I just think the ideal picture to me is a Cherokee physician treating Cherokee families. And I'm not sure we have a lot of that now, because medical school is a tough sell, particularly for our Cherokee students. It's a tough sell because they know what they're up against, 4 years of undergrad, 4 years of medical school, 3 or 4 years of residency. Right, Dr. Nolan? It's a tough sell. But if we were to make this commitment, I don't know what that might be, if we could sponsor 2 students in each class and have 8 students in the pipeline, and then just, in this joint venture getting ready to move into, if we know that we've got some of these Cherokee physicians in the pipeline, I think that might meet some of our healthcare needs, not all, but at least it'd be a good start. So I just wanted to expose the council to this, these figures. If you glance at them, Oklahoma schools about $50,000 a year. So if you do the math, if a Cherokee student goes to medical school now for 4 years, they're going to be about $300,000 in debt, unless they get some financial aid. It takes a long time to overcome $300,000 in debt. But any questions?
Mr. Chairman?
Yes.
I'll have these others to go back.
I'm curious, is this for a physician or is this for a mid-level provider?
What you have in your hand, just the medical school, physicians.
Okay.
Yeah.
That's all.
Both for OSU's osteopathic, OU's allopathic, yeah, both the state institutions.
Okay.
Wanda?
I know that our primary interest for medical school, our facilities would be Cherokee students. Are we working with tribes throughout the United States? Because as we travel, Chief Baker, he always shares his information with them. Hopefully that maybe we, of course, we're talking primarily to Cherokee citizens, but are we working with other tribes, or do they have this information that we could, of course, like I said, primary tribe would be Cherokee, but other tribes that could come to this school? And
Well, Stephanie Wycliffe is our medical recruiter, and she's all on board with this idea along with our health administration, but we actively recruit Cherokee physicians, and then next is any native physicians. So I think the word's out to other tribes as far as our opportunities. And so we certainly we hire a lot of other native physicians other than Cherokee.
Thank you.
The IHS scholarship that they give to Native Americans for medical school, is there a possibility that we could have conversations with some folks at IHS to possibly partner in this IHS scholarship, which would cut down costs for the federal government as well as cut down costs for us for these medical students, and then we can get dibs on these students to come to our clinic instead of another IHS facility? That's something to keep in mind on that partnership there, and the years would be the same as far as giving back to the hospital.
Yeah, I'm not sure, David, that the idea of kind of a partnership, in other words, cut this half and half between IHS and Cherokee Nation.
Because the IHS, they kind of direct you where you're going to go. You might have some say in it, but essentially they're going to tell you where to go because it's their money they invested into you. So
yeah, the IHS, as you mentioned, the new Cherokee graduate from med school, IHS may say, well, we need you here.
Yeah.
We need you in North Dakota. Sorry, you can't go to work in Oklahoma. So yeah, they pretty much have the upper hand on where that young student goes.
Yeah.
What you just said has happened to us. In fact, that they thought they were going to be directed as to where they were going to go, so they didn't go into our, what is it, Brian told me, directed studies. I had to ask my fellow counselor what that, I've forgotten the name of it. We do some of that in education, but we do so little of it. It's expensive.
Yeah, it is. I've got figures on that as well. I think currently we are funding 3 osteopathic students. We had 1 graduate, so now we've got 2 in the pipeline. And I think we fund 1 dentist, 1 nurse practitioner, and 1 substance abuse counselor at this point. So it is just not much.
It's a smidgen, but it's a start. And if you compile this onto it, my hand's going up if you want to get something going.
You know, Mr. Chairman, this is a good thought here. I think we've got to start somewhere. And we can direct some funds in that direction. And I'd like to get with Dr. Nolan and Brian and Dr. Grimm and say, where are the needs? I know there are needs all over, but where would be the most pressing needs that we could invest some funds in? And get back with us and get with the chairman. Let's see where we can take this option that you're suggesting here. 'Cause this is a good thought, something we need to look at.
It is.
Any other thoughts, questions? Okay,
Make a motion to adjourn.
well, not quite.
Oh,
Announcements. Real quickly, I got to Brian. Operation Orange, I announced last month, that's at the Sequoia Gym on Thursday, 9 to 3, basically for high school age students to come and just see what it's like to be a medical student. Invaluable opportunity.
What time is that?
9 to 3, I believe. I believe that they probably have same-day registration there as well. That's just an invaluable way for a high school age student to come and just get first-hand look. They may come and say, I don't want to do that. That's good for them to know. Or they may come and they're all in. So that's just an invaluable opportunity. Councilman Brian.
Yes, sir. Thank you. I brought this up last health meeting, and I talked about the subcommittee for public health, and and I've talked at length with the administration, with healthcare as well, and they're in support of this. So I would like to propose that we do a subcommittee of public health to be ran on the opposite dates of the culture committee at that same time. So like next month in July is culture committee. In August at 11 before E&F, we would do the public health committee, and I put that in the form of a motion.
Motion to second, and the motion again, Brian, is for Shelley's purposes.
For subcommittee for public health.
Okay.
every other month.
Any questions? All in favor? Aye. Opposed? None? Okay, entertain a motion to adjourn.
So moved.
They got something here.
Oh,
Never mind.
let me see.
I forgot one important thing on the highlights of the project. I think the council would be interested in is that we have contracted over $33 million with Terrell certified businesses on this project. The number will continue to increase each month as more opportunities come available. So,
Good job.
Yeah.
John?
Yes. Subcommittee Brian's talking about, it's gonna be a great one, and this may or not be the place, but we need to get together and let the Veterans Center report to us the things they have going on at no fault of anyone. We sometimes in the dark of that. Barbara's doing her darndest to get it out to us, but I'd like you all to think about having the Veterans Center, which we all hold in high regard, our veterans, coming and reporting it, making time for them to come here as well. So y'all think about that. Speaker, you're probably in control of setting that up, but I wanted y'all to think about that.
Okay, thanks, Sean. Before we adjourn, Rex, what time do you want to commence your next meeting?
10 minutes.
10 minutes? Okay. I think we ought to vote to adjourn.